Welcome, everyone. We're going to start the next session, session 3, entitled Cabbage in Women. So thank you all for coming.
And to get the session started, I'll introduce my co-moderator, Dr. Jennifer Lawton, the Chief of Cardiac Surgery at Johns Hopkins, and a passionate advocate for coronary surgery, particularly arterial grafting, and also for the role of women, both as medicos but also as patients. So Jennifer will talk to us about the results of cabbage in women. Thank you.
Thank you very much. It's been a very exciting morning so far. I don't have any disclosures that are financial. My only disclosures are that I'm a coronary surgeon, and my comments will be my own opinions, my own views, and will reflect my practice. I'm going to talk a little bit about outcomes are different between women and men, and then how we can improve them. And this is just one picture on my slides that I have multiple pictures of throughout my talk of days in the operating room when the entire team was female. So women are different from men. That's one of the reasons why outcomes may be different, and it's likely multifactorial, which we'll talk about a little bit this morning. We know that diabetes is a more potent risk factor in women, and that women are more likely to have non-diagnosable disease on coronary angiography and small vessel disease. They tend to be about 10 years older than men when they present with cardiovascular disease. They tend to have multiple risk factors and comorbidities, and we'll talk a little bit about that later, about how because of this, they're a little bit harder to propensity match with men. They more often present with an emergent or urgent presentation. Therefore, they also have a more severe anginal class, are more likely to die of a silent heart attack, have sudden death, and they're more likely to die within 1 year following a myocardial infarction. And this is a very old article here from Time magazine, Those Fragile Hearts, Who Dies from Heart Attacks? Surprisingly, more women than men. So women, we know from a lot of retrospective studies that they're more likely to have atypical symptoms. That doesn't mean that they don't have the classic chest pain, but they're more likely to come in with fatigue, shortness of breath, abdominal symptoms, or gastroesophageal reflux disease type symptoms. So that could also weigh into the fact why outcomes are not as good in women following cabbage. They tend to be caregivers for others, so they may postpone their own medical care, or they may not come to the emergency room with that pain that they have. And they delay their own treatment presentation because of these things. We know that when they do come, they're less likely to get guideline-directed medical therapy. It takes a longer time from presentation to admission to the hospital and to treatment. We know that when physicians evaluate women with the same exact risk factors that men have, they're assigned to a lower risk category. And much of that may be from decades ago when heart disease was felt to be only a disease in men. And actually the American Heart Association had sessions on how do I help my husband cope with heart disease years ago. So they're less likely to get guideline-directed medical therapy when they do come. They're less likely to be referred for cath, stress testing, and for surgery. And we've already heard a little bit more about randomized trials in our specialty. Largely what we do to our patients in the operating room is based on trials largely in men. And we know that women make up about a third of the patients that we operate on for bypass. One of the reasons why outcomes may not be as good is also perhaps a knowledge deficit, not only in patients, but clinicians. So many people, including us, may not know that from 1983 to 2013, more women than men died in this country from cardiovascular disease. And it is also the #1 killer in women, which means more women die of cardiovascular disease than all cancer combined. So you see so many advertising, and you see NFL players wearing pink for the day on a game, and I wish they would wear red one day instead. This is a slide of traditional risk factors for cardiovascular disease on the left, which we are all very familiar with. But on the right, a lot of patients, a lot of surgeons, and a lot of OBGYN physicians don't realize that preterm delivery preeclampsia during pregnancy, gestational diabetes, and autoimmune disease, breast cancer treatment, and depression are unique risk factors in women. So something happens at the time of pregnancy in the placenta that does not ever change back. And so women who have these complications during pregnancy when they're in younger years, they need to know that they're at risk for cardiovascular disease later in life. So another thing that we know is that health disparities by race and sex are evident across the spectrum of cardiovascular disease. And this is a recommendation from the 2021 AHA-ACC SKY guidelines, and that women and non-white patients are less likely to receive guideline-based therapies, but they do benefit from these therapies. And so there's a class 1 recommendation indicating that benefit greatly outweighs risk, that when patients require coronary revascularization, treatment decisions should be based on clinical indication, regardless of race, sex, or ethnicity, to reduce disparity, and efforts to reduce disparities are warranted. So I realized that this several years ago when I was sort of, I think, treating my patients differently when I made operative plans. So I came up with this algorithm, and I decided I'm gonna walk in the room with every patient, no matter what the patient looks like, and I'm gonna assume I'm gonna do bilateral mammaries and a radial graft in every single one. And then I only go through this algorithm for reasons why I might not use those grafts. So sort of having implicit bias training before you see the patient. So what about operative mortality? Well, it's difficult to do a randomized trial between men and women, obviously, but if we look at retrospective studies, many going back years and years, we know that women were found to have a higher mortality with coronary artery bypass grafting, and sometimes as high as 3 times in younger patients. If we look at propensity matched studies or risk factor matched, we find contradictory findings, and I'll show you a little bit of those. I'll show you a meta-analysis of 4 randomized trials and some age differences. So what about retrospective studies? Well, this was a retrospective study that was published in Circulation in 2002, so more than 20 years ago, but it made this newspaper, USA Today, because the title in that newspaper was "Women Face Triple the Danger from Bypass Surgery." You can imagine that got a lot of patients and clinicians worried. And what they found was that when women had CABG that were less than 50 years of age, the mortality was 3 times that of men, and that as women get older, that difference actually declines, which is one of the reasons why I don't believe that it's all due to smaller coronary arteries, but we'll hear a little bit about that from Dr. Zwischenberger. This is a much more contemporary retrospective study in patients who are Medicare beneficiaries. 1.8 women were in this study, including many men. And you can see on the far left, in-hospital mortality after CABG, in the middle, 30-day mortality after CABG, and on the right, 1-year mortality, women in blue, men in orange. So the mortality after CABG in women remained higher than that in men across all years of the study. This is another very large retrospective study, and we see here, this is based on the national inpatient sample, and women were much more likely to die, and we got an indication here at the bottom that they're also less likely to get an IMA graft, and we'll hear more about that in the next few talks. What about propensity score matching? So this slide shows you that when you try to propensity score match women and men, you don't get a very high rate of matching. So in these 3 studies, you can see that only 26% of women, or a higher rate in the third one, of women could actually be matched to men, so that they're very different patients when they present. When you look at studies that do have propensity matching, when the women look like the men, the mortality is not different after CABG. This is one of such propensity match studies, and here we see actually mortality was higher across the 13 years of this study, and this persisted over 13 years, or 14 years. This is another one. This includes 2 prospective multi-center studies. There were almost 2,000 matched pairs of men and women, and you can see on the left, in the propensity matched groups, higher mortality in women, and it was largely due to mortality in the first year. Here we can see PCI, cumulative incidence of PCI in women much higher following CABG, and myocardial infarction on the right. Yet another one of more than 14,000 patients, propensity weighting, and this one, I mentioned there's controversial data. On the right, you can see cumulative adjusted mortality rate was actually higher in men in these patients, and MI rate was higher in women on the left. Yet another one, you can see the overall cohort on the left. So you can see that men had a higher survival following CABG in that cohort, but on the right, when they were matched with women, no difference. So what about a meta-analysis of 4 randomized controlled trials? Gaudino and colleagues, this is a patient-level meta-analysis of 4 trials. Women had a higher rate of MACE, you can see on the right, but there was no difference in mortality. So again, varying results of multiple different trials. And what about age differences? I mentioned earlier that younger women had a much higher mortality in 2002 in the Vaccarino study. This is a more contemporary study, which I showed you a few minutes ago, some other results. But this is looking at patients who are less than 70 years of age on the top and greater than or equal to 70 years of age on the bottom. And you can see the mortality flips, and that in the younger patients, women were more likely to have a higher mortality than men, and the reverse is true for the older patients. So how can we optimize outcomes in women? I gave you the example of the algorithm that I use. We need to involve more women in clinical trials. As Mario mentioned, the importance of clinical trials in our field. We need to have effective diagnostic tests in women. We have to make our patients aware. We need to make our clinicians aware of the prevention and delayed diagnosis, the treatment conservatism, and the referral bias. We also have to utilize guideline-directed medical therapy and surgical therapy in our patients. So when they come back to see you after surgery, you have to reiterate the risk factors that we need to modify now. And then there are intraoperative factors, which I won't go into. You'll hear other people talk about them. Use arterial grafts in women, provide complete revascularization. You'll also hear a little bit more about coronary specialization and the ultimate specialization, concordance, which I'll skip this slide. So improvements in women, this is a call to action. That's a quote from Dr. Zwischenberger. And this is a quote from Maya Angelou: do the best you can until you know better. Then when you know better, do better. So I think we know how to do bypass surgery well. And for me, this means use more arterial grafts in women. These are some of the women that take care of patients at Johns Hopkins with cardiovascular disease. Thank you for your attention.
Thank you, Dr. Lawton. That was absolutely excellent overview. Just to delve into things a little bit further in depth, particularly with arterial grafting, it's my pleasure to invite Dr. Sigrid Sand to the stage. Sigrid is the chief of coronary surgery in the University of Vienna hospitals and a passionate advocate of coronary surgery and arterial grafting, and in particular she's the new chief of the working group at the European Association of Cardiothoracic Surgery. Thank you, Sigrid.
It's a very kind introduction, James. Thank you very much. Thank you for the honor of the invitation and the privilege to present. So I've been tasked with trying to answer the question of whether women may actually derive more benefit than men from arterial grafting. And we know that grafting strategies are different between women and men, in that women far less frequently receive arterial graft. And Dr. Lawton has alluded to this study that was published in the Annals a couple of years ago, showing that women less frequently than men receive bilateral internal thoracic artery grafts, they less frequently receive radial artery grafts, and overall they less frequently receive multiple arterial grafting compared with men. And this finding that women receive less arterial grafting is a consistent finding in virtually all analyses of multiple arterial grafting, and it persists even when we, in our analyses, statistically adjust for baseline risk factors between women and men. So the question then is, do women even benefit from multiple arterial grafting? And this is a meta-analysis of observational studies, and it shows that the answer to the question is yes. Also in women, when you use more than one arterial graft, you're going to have better long-term outcomes. But obviously, these are observational studies, and we also know that observational studies are confounded by particularly our clinical judgment, because it's our clinical judgment by which we make the decision about which grafting strategy we're going to use. And this is going to include factors that are outside of the traditional baseline risk factors that we can then use in our adjustment models. And I think that this is particularly even more true when the patient is a woman. So do we have any evidence from the very few randomized trials that compared multiple with single arterial grafting strategies that would suggest that there is a differential treatment effect of multiple arterial grafting between women and men? These are data from the radial analyses that looked at radial artery versus saphenous vein grafts for the composite outcome of death, MI, and repeat revascularization. And you can see both in the 5-year and in the 10-year analysis that women derived a significantly larger benefit from use of the radial artery versus the saphenous vein than men did. And when we look at the RAPCO trial in the radial artery versus saphenous vein comparison, you can see that sex, or that there was a signal, sex as a treatment effect modifier for the primary outcome. So the effect appears larger in women, but the p-value for interaction is non-significant, so this is non-significant. And even in the ART trial that, as we know, was neutral for the beta versus zeta comparison, if you look in women at the point estimate for the hazard ratio was 0.78. So it was in the direction of benefit, but also not significant. And the thing is that these are all subgroup analyses of randomized trials, and they're by definition underpowered. And you can see that the proportion of women in these trials is very low. So this also holds true for the Roma trial, in which the proportion of women was 16%. And Dr. Gaudino has mentioned this in previous talks. It is also true that for the Roma trial, if it were to be neutral, then a potential differential treatment effect of multiple arterial grafting in Roma would either be lost or diluted, which is why it is so important that we do Roma women, which is powered for outcomes of multiple arterial grafting in women. Now, the question is, why would we think that the benefit of multiple arterial grafting would be greater in women, or what is the underlying mechanism why it could be greater? And I think that there is a different risk to benefit ratio of multiple arterial grafting between women and men. So on the risk side, for women, you have an increased risk of harvesting site complications, particularly sternal wound complications. This is, as we know, particularly true for the RITA, and very likely the reason why there is an underuse of the RITA in women. The use of arterial grafts in women may or may not be technically more challenging. I think it is. Grafts are smaller in women, they're more fragile, they're more prone to spasm, so are the coronary targets. This is a biological reality. So what is the benefit? And I think that the benefit is in the difference in the quality of the graft. And obviously this applies to both men and women. So the quality of arterial grafts, of radial artery grafts, of internal thoracic artery grafts are going to be better in men and in women. But I think that the extent of the benefit is likely greater in women, because we know that the vein graft quality is so much lower in women than in men. Vein grafts in women are more frequently diseased, they're more varicose. We know that female sex is a risk factor for vein graft failure, and it's not female sex as some abstract concept. It's a multitude of factors, and one of them is an underlying difference in vascular graft pathobiology. And I think that particularly in women, better patency rates of arterial grafts could translate into disproportionately better clinical outcomes in women. Also, we have longer life expectancy, so the benefit of arterial grafting, we would expect it to accrue over time. So to summarize, do women derive more benefit from arterial grafting than men? There is observational evidence that multiple arterial grafting is beneficial and also beneficial in women. In the very few randomized trials, there's a signal that the treatment effect may be different by sex and larger in women. But in all of these trials, the proportion of women so far has been low. They've only been subgroup analyses or secondary analyses. Again, this is so important that we do the Roma Women trial. It is biologically plausible, I think, that the benefit may be greater, but I do want to add one caveat. I think that if there were a greater benefit, it can only be realized if there is no associated increased procedural risk with multiple arterial grafting in women. Thank you.
Thank you. That was excellent. I look forward to the panel discussion in a few minutes. Our next speaker is Dr. Brittany Zwischenberger. She's a cardiac surgeon at Duke. She is the senior author of the paper that Dr. Sandner just mentioned, where in millions of patients in the STS database, women were less likely to receive radial, lima, and rema. Thank you.
Thank you so much. I'm so excited to be here to discuss technical challenges of CABG in women. No conflicts. So in the 2021 ACC-AHA revascularization guidelines, there was a specific class of recommendation 1 for treatment decisions to be based on clinical indication regardless of sex to reduce disparities in care. So that really sets the stage for what we've been talking about today. The sex differences in outcomes there are sex differences in outcomes after CABG. Women experience increased mortality, as we've heard, late mortality, MACE, myocardial infarction, and stroke. And why is this? As we've heard, this really touches on the entire experience for women around CABG, starting from symptom onset to long-term benefit. Physiologic differences, barriers to access, and referral bias are just the beginning. So what's the solution? It's to critically review every single step, which is what we're doing here today. So preoperatively, we've learned that coronary artery disease is different in women, and these differences are being seen in the functional and anatomic assessments in our modern imaging. So as imaging improves, we are seeing these nuances, and the literature is explaining how we can use these tests differently and interpret the tests differently for women, and multimodal is best. We're seeing with CT scan that women indeed have more non-obstructive coronary artery disease. Women are more sensitive to the bedside manner. They're more perceptive to the absence of empathy from a surgeon, and shared backgrounds can help connect surgeons to their patients. And this may affect their decision to accept or decline CABG. So how can we connect with women? Intraoperatively, the ACC-AHA revascularization guidelines do list radial as a class 1 recommendation. Left internal mammary is a class 1 recommendation to the LAD, and bilateral internal mammary is a class 2A to improve long-term outcomes. But as we've heard, the STS database demonstrated that women are less likely to receive an IMA to the LAD. Women are less likely to receive bilateral internal mammary, less likely to receive radial arteries, and less likely to undergo complete revascularization. The reasons identified for not using lima, which we have to report to the STS when we're not using the left internal mammary, for women, it was more likely documented that it was an emergent or salvage procedure, that they had previous mediastinal radiation, that they have subclavian stenosis, or an inadequate size or flow. Let's stop there. Is radiation for breast cancer a contraindication for the lima usage? We need to stomp out this dogma. What about subclavian stenosis? Can we use a stent to stent open the subclavian artery so that we can use the lima as a pedicle? So multi-arterial grafting can be good for men and women. Women, it's demonstrated in a meta-analysis of women only that they experience a reduction of death at 10 years with multi-arterial grafting, and they experience a reduction of MACE at 10 years with multi-arterial grafting. So how are we educating the community on the use of the right internal mammary and the radial harvest techniques so that we can realize the benefits these studies are demonstrating? But to go deeper, to look at the nuances between right internal mammary and the radial, we are seeing a difference in early outcomes by graft selection. So in this national UK database study, in-hospital mortality was higher in the RITA group compared to the vein group with an odds ratio of 2. The sternal wound infection was also more likely in the RITA group compared to both radial and vein graft. And then sternal wound infection was associated with a higher risk of in-hospital mortality with an odds ratio of 8. So certainly we haven't proven causation, but there are very strong associations. And looking at late outcomes in this meta-analysis of randomized controlled trial with the radial investigators using radial artery and vein graft, in the subgroup analysis, sex was significant, with women realizing a greater benefit from radial. So how are we choosing our arterial grafts in women? What is our algorithm? Women indeed have smaller coronary size, and that contributes to increased technical complexity. Using CT scan with 383 males and 327 females, women had smaller diameters of the left main, the LAD, the circumflex, and the right, even after adjustment for body habitus. And this smaller coronary size has an effect on early mortality. So in-hospital mortality for patients with a 1 millimeter LAD was significantly worse. So smaller coronary arteries had worse early outcomes. And the LAD diameter was different by sex. So women were more likely to have a 1 millimeter diameter or 1.5 millimeter diameter coronary artery. So is this a good resident teaching case? How are we choosing the cases that we have the residents participate? Is this a good one for them to practice, especially younger residents? So the European Society 2018 guidelines recommended use of transit time flow measurement for graft assessment. It's a 2A level of evidence B recommendation. In this study by Dr. Taggart, there was a change in the surgical strategy in a quarter of cases with using flow probe or epi-aortic ultrasound. And most of this was driven by the flow probe usage. So we have an algorithm of how to make a decision to revise the graft, which is published. And there's specific criteria. The pulsatility index should be less than 5, with the diastolic filling percentage greater than 70% for left-sided grafts and greater than 50% for right-sided grafts. Should this be studied based on sex? We've heard that there are different sizes of the coronaries. Do we need to have a better understanding of how the flow probe will appear for women? Internal mammary harvest techniques, skeletonized versus pedicle, is a long debate. In this study of SPECT image of postoperative sternal perfusion, the left side of the patient has a skeletonized IMA and the right is a pedicle. The total sternal perfusion was higher on the skeletonized side, significantly different. And the greatest difference was in the upper third of the sternum. So with this increased risk of sternal wound infection, should we skeletonize more often in women? And postoperatively. So as we discussed, that women have an increased risk of wound infection. In the study of bilateral internal mammary arteries, 79 female and 392 males, both superficial and deep sternal wound infections were more common in females. Not just more common, 26% of patients versus 5% of males. This is astounding. So what quality improvement initiatives do we have in place to minimize wound infection for all of our patients, which we know has a huge morbidity, but specifically women? Are we making sure that all of our patients get a surgical bra? Does it fit well? Do they get an extra one for home? These kind of nuances are what really will determine the success of our surgery. Post-op wound care, post-operative blood glucose management, especially for the women who are not taking care of themselves, and nutritional optimization. Are they going home with protein shakes? Have we found a good store for them to get them for a reasonable cost? So how are we tailoring our post-op management strategies to women? And long-term. So are there reasons that the treatment effect may be different in women? Yes, because women are different. As Dr. Gaudino describes in this figure, there's different baseline operative risk profiles, higher procedural risk, increased technical complexity, smaller coronary arteries, and the conduits are more prone to spasm, higher prevalence of microvascular dysfunction, and lower quality of venous conduits. And we all know that CABG is more nuanced than these trials are representing. There is a lack of diversity. The randomized controlled trials in cardiac surgery are 80% white males. It's just not perfectly applicable to all of our patient population. So much so that the American Heart Association issued a scientific statement on methodological standards for the design, implementation, and analysis of randomized trials in cardiac surgery. Marrying the two, we've come up with Roma Women. So I do want to take a moment on this study. This is an observational study by Dr. Tora Grossa, who's here today. The title is Robot-Assisted versus Conventional Off-Pump Coronary Surgery in Women. When I saw this article, I was really moved, and I went back and looked at my own minimally invasive CABG cohort. So nationally, women make up 13 to 20% of CABG. In my minimally invasive CABG cohort, it's 47% women, which I didn't really realize at the time when I read this article. And a lot of these women were brittle diabetics who were obese with large breasts, and we could tell by the eyeball test that they weren't perfect for sternotomy. So, while Dr. Gaudino who's my mentor, would really want us to use this as hypothesis generating, I think that this is a good starting spot to ask a different question for women. Not just is off-pump, on-pump good for women, but specifically how can we use it in which female patient population? So in conclusion, the existing literature shows that sex-related differences in outcomes exist after CABG. And future research includes searching the driving mechanisms for the differences, developing techniques to eliminate the differences, and disseminating and implementing quality improvement metrics. The rising tide lifts us all. You don't have to look like her to help improve outcomes in women after CABG. Thank you so much.
Thank you very much, Brittany. A terrific overview from start to finish, so I'm sure benefit will come. Next up again is Dr. Mario Gaudino, who will talk to us, who needs no introduction. He'll talk to us about why women are underrepresented in clinical trials and what can we do about it. Thank you.
Thank you, James. Thank you, Brittany. No one called me a tormentor before. I kind of like it. And I think a lot of my fellow in the room would agree on that. So we will use that. Okay, so my task is to discuss why women are underrepresented in CABG clinical trial. And look, over the course of the last 2 decades, essentially everyone, the NIH, the FDA, professional societies, probably even tennis clubs have put out statement, papers, call to action to include more women and to have a more diverse population. They have not been very successful in general, and in cardiac surgery in particular, they for sure have not been very successful. This is a systematic review and meta-analysis of the cardiac surgery trial published over the course of 20 years, from 2000 to 2020, and the overall proportion of women included was 20%. This proportion was lower in non-European trials and was lower, significantly lower, at 16% in CABG that were testing, in trials that were testing CABG interventions. So why is that? What are the reasons behind this underrepresentation? Well, there are several reasons. As always, is multifactorial. There are issues related to patients and to difference between sexes. Women more often have family and child care responsibility. They have less time and they're less willing to take time to participate in clinical trial. They have less often access to transportation. They may less likely to be able to take absence from work for participation in trial activity. It has been shown that women perceive a higher risk from participation in trial when informed. This is most likely due to the fact that the language we use and the communication strategy we use to inform a patient are heavily targeted to a male population, and the communication must be different by sex. There are financial, psychological, socioeconomic, and cultural barriers that are much more evident for women than for men. But there are also trial design issues. There are exclusion criteria that penalize women much more than men. A classic example for CABG trial is the age cutoff. Women are referred later in life to surgery, so any age cutoff will affect women more than men. Just as a reminder, childbearing potential, that was the definition, has traditionally been an exclusion criteria in clinical trial for over 20 years. It clearly doesn't affect men. There is limited representation of women in trial leadership, and this has been shown to be a limiting factor for the enrollment of women. There are lack of sex-related eligibility criteria. However, it is possible to be successful. I am thankful to the BioLibra investigator. This is a heart failure trial where 60% of the population included was women. The BioLibra investigators were committed to achieve this goal, and they were able to do that using a multimodal strategy. They championed female recruitment at participating site. The research team was made for the majority of women, and the communication strategy and even the consent form were specifically written with women in mind. And then there was a study design and selection criteria that were different by sexes. I think what is also very important, and we have learned that in Roma women, is a connection with the referrals for cardiac surgery. And it's important to make referral aware of interest in women's health and potentially of the fact that the trial dedicated to women is ongoing. In Roman women, we have heard from many centers that they are getting selective referral of women because in need of CABG, because they are participating in the first cardiac surgery trial dedicated to women. And we have learned from the heart failure literature that there is a very strong statistically significant association between the number of women that are included in trial leadership and the number of women that are enrolled as a patient in trials. But now I want to change the question that has been assigned to me. And I want to ask if are women underrepresented in clinical trial, or are women with coronary artery disease undertreated, in particular by CABG? If we look at the recent US statistics in 2019, women represented 48% of the deaths from cardiovascular disease and 40% of the deaths from coronary disease. But they did represent 16% of the patients in CABG trial. So the math just doesn't add up. We have known for 30 years that women with coronary artery disease not only are diagnosed less frequently, but they are less likely to undergo catheterization and coronary revascularization. This was the seminal paper in the 90s of NIJM that looked at it for the first time, but even more recent data haven't changed. We have recently looked at the modality of revascularization in the United States from 2019 to 2020 for all patients with triple vessel disease who had an indication to coronary revascularization. And you can see in the graph how women were significantly less likely than men to undergo bypass surgery. And this is when they did undergo a cut, did add an indication to revascularization and had the revascularization performed. And then, for the purpose of this presentation, we did some interesting exercise. So we used publicly available data from the ischemia trial. And with all the controversy that we have heard before, ischemia is a great model for this question because, in ischemia, patients were randomized to two arms. One was a medical arm, a conservative one, and the other was an invasive arm. And patients randomized to the invasive arm were supposed to receive catheterization, cardiac catheterization, and then revascularization if indicated. So we ask ourselves the question, okay, was there a difference by sex in the rate of revascularization for patients in the ischemia trial that were randomized to the invasive arm? So those were patients that technically should have all had revascularization. Well, women were significantly less likely than men to receive coronary revascularization even when randomized to the invasive arm in the ischemia trial. And when we look at the difference by revascularization strategy, look at how women had 50% of the chance of receiving CABG compared to men when they were randomized to the invasive arm and there was an indication to revascularization. So clearly, women are undertreated, under-revascularized, and in particular, under-revascularized by surgery. Now, a few years ago, a very smart fellow of mine looked at the difference in baseline characteristics between randomized trial and large clinical registry. It was a very large analysis, more than 2 million patients, 14 randomized trials, over 10 national registries that were capturing the entire clinical practice of a nation for PCI and CABG. We found a significant difference in a number of baseline characteristics between patients that were included in randomized trial and patients who were included in registry. However, the representation of women was not different. It was 26% in registry and 24% in randomized trial. So actually, I would argue that randomized trial do mirror clinical practice, and women are not underrepresented in CABG trial. The representation of women in CABG trial is exactly the same representation of women that we see in clinical practice. Now, clinical practice is probably wrong, but in terms of trial representation, there is no difference. We also looked at leadership of cardiac surgery trial, and we found no surprise that only a small minority of cardiac surgery trial had women included in leadership, and this percentage did not increase over the course of the study, over the course of the years. However, in cardiac surgery, we did not see that association between women included in trial leadership and enrollment of women in trials. And my explanation for that is that women included in leadership in those trials were not surgeons. They were statisticians, they were methodologists. It's important that surgical trial include women as a surgical leader, not in a supportive role. And there are innovative design, and we have discussed Roma women. Thank you, Brittany, for doing that, so I can quickly move to the conclusion. So, my conclusion is that the representation of women in CABG trial in fact mirrors clinical practice. But the number is just too low to allow meaningful subgroup analysis in trials that are dominated by men. The problem is that women with coronary artery disease are underdiagnosed and under-revascularized compared to men. And look, this might be due to difference in CAD phenotype, baseline characteristic, or to referral bias. I think that this is where we have to work. And clearly, new trial design and trial dedicated to women are needed. Thank you.
Thank you very much, Mario. It's my pleasure now to introduce our last speaker of this session, Dr. Lemia Harik from Cornell, and she's going to speak about, do women patients benefit from having a female surgeon? Does patient-surgeon gender concordance matter? Welcome.
Thank you, Dr. Lawton. Thank you for the opportunity to speak today. Always humbling to follow Dr. Sandner, Dr. Zwischenberger, Dr. Godino, and Dr. Lawton, all who I admire very much. But I'll begin with my talk. Do women patients benefit from having a female surgeon? Does patient-surgeon sex concordance matter? Now, female patients with cardiovascular disease have well-described poor outcomes. You've already heard about that from Dr. Lawton today and the others. And that's particularly true after CABG, and that disparity has remained unchanged over time. Now, here I've listed some of the previously proposed drivers for the sex disparity in outcomes, which again, we've already heard about today, but these have ranged from baseline anatomic, biologic, and functional characteristics that are different between the sexes, differences in timing and acuity of clinical presentation, and differences in management or grafting strategies as well. But emerging data has suggested that the importance of patient-physician or patient-surgeon sex concordance may play a role here as well. There have been some examples of these, not too many in the surgical literature, but others in cardiovascular and medical literature, and I'll just present a couple. One highly pertinent example is a 2018 study of over 500,000 patients, 10% of which were women, all who presented to emergency departments with myocardial infarction. And this study found that patient-physician sex discordance was particularly harmful to women. So the baseline mortality rate in the whole cohort was 11.9%. But after matching each woman to a man treated by the same physician in the same emergency department in the same year, women treated by male physicians were the least likely to survive. They had a lower probability of survival by 1.52%, representing an approximate 12% decline from the baseline mortality rate. Now, men who were treated by male physicians only had a 0.38% lower probability of survival. And in fact, women who were treated by female physicians had a 0.27% higher likelihood of survival. Now, there was another population-based retrospective cohort study using the Ontario Provincial Database that was published about a year ago, where Wallace and his team looked at 21 common elective or surgical procedures, so not just cardiac, all procedures and surgery. And to date, it's the only surgical paper with a main analysis intended to evaluate patient-surgeon sex concordance as the primary exposure. Now, this included over 1.3 million patients treated by almost 3,000 surgeons. About 500,000 of these patients were men who were sex concordant with their surgeons, so treated by men. And it included 92,000 women who were sex concordant with their surgeon, treated by women. The remaining 700,000 patients were sex discordant, and the overwhelming majority of the sex discordant patients were women who were treated by male surgeons. Now, their primary outcome was mortality, readmission, or complication, and that was defined per each surgery. So what did they find? On multivariable analysis, patient-surgeon sex discordance was associated with the primary outcome in female patients who were treated by male surgeons, when compared to the reference of female patients treated by female surgeons. But there was no association of patient-surgeon sex discordance with the primary outcome in male patients treated by female surgeons. So this again is showing us that patient-surgeon sex discordance is particularly harmful to female patients. Now, they did do a pre-specified subgroup analyses based on surgical specialty. And in cardiothoracic surgery, sex discordance was associated with a higher risk of the composite of death, readmission, or complication, with an adjusted OR of 1.1. Now, female patient sex concordance in cardiothoracic surgery was associated with a trend towards better outcomes. The p-value isn't reported here, but it just wasn't significant, and that's likely because of the rather low number of female cardiac surgeons who were included in this cohort. So given that this emerging data is suggestive of a positive relationship between sex concordance and outcomes, particularly in women, the obvious question is, why might that be? Possible mechanisms include superior communication skills, maybe leading to better adherence in patients of female physicians, better overall outcomes with female physicians, or an emphasis on preventive or guideline-directed care by female physicians. And maybe even the absence of implicit bias is helpful for female patients as well. Now, several studies have found superior clinical outcomes of female physicians, irrespective of patient sex. I'm just presenting the most recent study of this in the surgical field. So Wallace, again, the same group that we just saw, presented another study of over 1 million patients who were treated by either a male or female surgeon, obviously. 150,000 of these patients were treated by a female surgeon. And this time they were just looking at 90-day and 1-year outcomes. And they find that after adjustment for patient, surgeon, and facility factors, the incidence of the composite primary outcome of death, readmission, or complication was higher in patients treated by male surgeons than those treated by female surgeons, both at 90 days and out at 1 year. Now, there were a lot of issues with that study that people raised and sort of made complaints about, and one suggestion was that female surgeons were just treating patients who were less medically complex. Of course, after adjustment, the results were what they were, but I looked into other studies that maybe had complexity stratified outcomes. Now, this is a retrospective study of Medicare beneficiaries, including 1.5 million hospitalizations and 58,000 internal medicine physicians, 32% of which were women. And this study found that even after adjustment, again, for patient, physician, and hospital characteristics, patients treated by female physicians had lower 30-day mortality with an adjusted risk difference of -0.43 and a number needed to treat of 233, and lower incidence of readmission at 30 days with an adjusted risk difference of -0.55 and a number needed to treat of 182. Now, what I've shown here is that when patients were stratified by severity of illness, ranging from the least severe and healthiest patients at the left in each figure and the highest severity of illness or sickest patients at the right, patients treated by female physicians still had significantly lower mortality in all but the second healthiest group of patients, and had the significantly lower readmission in all but the healthiest strata of patients. So this may provide a counterpoint to the suggestion that better outcomes among female physicians may just be due to the fact that they're not treating high acuity complex patients. Now, several other studies have also shown that female physicians place a greater emphasis on preventive care and guideline-directed medicine than do their male counterparts. This is a study of over 30,000 primary care visits from a national ambulatory care database. And here they found that female physicians were more likely than male physicians to perform preventive procedures. And I want to point out that this is not just for sex-specific preventive care like mammograms. It was also for things related to general and cardiovascular health, like cholesterol testing or diet and nutritional counseling and exercise counseling. And all of the things that were, all the activities that were performed here were guideline directed by the USPTF. Physician communication skills have also been associated with higher levels of patient adherence, as well as better clinical outcomes. And it's been suggested that female physicians have superior communication skills compared with men. Now, this is a meta-analysis of 26 studies, 23 of which were observational and 3 physician reports. And they found that while there were no differences between male and female physicians in the amount of biomedical information given during a patient visit, female physicians exhibited significantly more psychosocial counseling, psychosocial question asking, partnership behaviors, and particularly active partnership behaviors, significantly more positive talk and emotionally focused talk than their male counterparts. And lastly, implicit bias, which I think Dr. Lawton mentioned in her talk briefly, of course plays a role in how we're treating patients. And I think what the main thing here is that the absence of implicit bias might be what's helpful for female patients who are treated by female surgeons. Now, of course, it's difficult, to combat implicit bias, but there have been some interesting findings to suggest how it might be done. If we go back to the Greenwood study on management of acute myocardial infarction in the emergency department, they actually had a very interesting finding. They said that they found that women with lower survival, that had lower survival in female patient and male physician pairs, that was attenuated as the number of female physicians working with that treating male doctor in the ED increased. So for every 5% increase in female physicians working in a given emergency department with a male physician, their female patients then had a 0.04 higher probability of survival, which again turned out to be about an 8% decline off the overall mortality. Now, this suggests that there is transferable knowledge from colleagues of the opposite sex, and that ongoing professional education on how to better diagnose and treat patients of the opposite sex might be one avenue to combat existing implicit bias outcomes and improve patient outcomes. Of course, there's barriers to studying patient-physician sex concordance, particularly in women. Dr. Gaudino has already given an excellent talk on this, so I won't belabor it, but there's not very many women participating in cardiovascular trials, which might be due to the dearth of women who are leading them. He's already addressed that. I would also say it's important to note that it's difficult to study something that is a surgeon factor in women when there are not that many female surgeons practicing in our field. Roughly 12% of cardiac surgeons are female, per a recent AAMC report, and this has only had slow and incremental growth over the last 30 years. Women also make up less than a quarter of interventional cardiologists per the AAMC, despite drawing from an internal medicine residency pool that's roughly half women. Now, given all that, it's difficult to conduct studies with female surgeons and cardiologists, and one example of that is a recent study in the Annals of Thoracic Surgery that attempted to evaluate operator characteristics and how that affected outcomes after TAVR, but they weren't able to evaluate operator sex because only 3 of the 75 operators in the cohort were women. So clearly, not just more women enrolled in studies, but more women in our field will help us to study if patient-surgeon sex concordance is helpful in improving outcomes. In conclusion, there is emerging evidence of a positive relationship between patient-physician and patient-surgeon sex concordance and clinical outcomes, and this is particularly true in women. Now, initial data are, of course, limited by their retrospective design, the relatively small number of studies on this topic in surgical or cardiovascular fields, by the dearth of female practitioners, and by low enrollment of female patients in cardiovascular studies. Of course, I would like to thank Dr. Gaudino, our entire team at Weill Cornell NYP, Dr. Girardi, and to the ICC for allowing me to speak today. I am grateful and humbled. Thank you.
That was an excellent summary. Thank you very much. We have a few minutes left. If there are questions for the panel, Dr. Puskis?
I thought this is a terrific session and a very, very important topic. I come at my question from the point of view of a big fan of females. Most of the people that I love most in this world have always been female. My mother, my 2 sisters, my wife, my 2 daughters. But I have a question regarding surgeon-patient concordance, which is obviously the hot button topic here. If there's some clinical benefit to female patients, from having a female surgeon, why is there no similar benefit to male patients from having a male surgeon?
Sorry. Thank you for your question, sir. So I think that's a great question, and we tried to outline what is in those final slides, what's going on that is driving this benefit in women preferentially when they have a female surgeon. I think implicit bias plays a huge role. And so male surgeons may underdiagnose, undertreat, underappreciate different aspects of disease that are unique in women. And that's why I think you saw in the Greenwood study that it's not that men can't treat women or shouldn't treat women, it's just that there may need to be some more ongoing education from female colleagues, from the literature, to pay more attention to female-directed literature and data, just so that we can continue to improve our practice. I think probably naturally female surgeons pay more attention to that kind of thing. When something comes out that's about outcomes in women, I always read it. I'm not sure that men always do, just because it's not as interesting to them maybe, or other factors. So I think there is ongoing education and improvement in practice that can happen. I don't necessarily think it's an inherent thing. I think we can fix it.
Yeah, and John, let me add to that because we have been looking into that with some skepticism at the beginning when we started reviewing the literature. And I mean, Lamia has done a fantastic job in summarizing it, and she has done a lot of work that will be soon published on this. It's a topic that is very difficult to investigate based on non-randomized data. There is a ton of confounders. The patient complexity may be different, but for sure what we see in different fields, medicine, general surgery, cardiothoracic surgery, is a constant signal that women treated by women do better. You never find in any field that women treated by men do better than women treated by women. So I don't know what's there, but as a scientist, when I see a constant finding in different fields, I tend to think that there may be something. And I think your question is great, but rely on the fact that you assume that if men have bias toward women, then women may have bias toward men. But that may not be the case. The two sexes are not necessarily symmetric. So there may be factors that are more prevalent in one sex than the other. I know it's crazy, but I love this topic for a randomized trial. I think this is the next trial that I want to do, because I think there is something there. I don't know what it is, and so that's get my attention.
I think you might be next.
Marvin Derrick, I practice just outside of Chicago. I've been doing this for a long time. I just wanted to ask you a couple technical questions. I've done a lot of coronary bypass. I've used a lot of arterial grafts, and I have had issues with, especially with women doing bilateral mammaries. And it's a horrible complication when it occurs, and it usually happens when someone's really young. That I want to make sure that they get the best arterial revascularization. And so let's start with right internal mammary artery. Are there any contraindications? Diabetics that are on insulin, obesity, previous radiation. I know a lot of times that radiation is given tangentially, so it probably wouldn't affect the mammary bed. And when you do use a right internal mammary artery, do you ever consider the fact of using it as a free graft so that you don't have a pedicle graft crossing the midline in case they need to be reoperated on? And then going to radial arteries, as you know, many people in this room have been burned by the radial artery spasming. I've always considered the internal mammary artery as being golden, next is the radial artery, and then finally saphenous vein. And the radial arteries look beautiful. But I've always been concerned about competitive flow. I've had to take care of some patients where these grafts have closed down, and sometimes they're on very important vessels. Is there a guideline with how much stenosis there has to be on the vessel before you'd consider using a radial? And if you do use the radial, do you ever have concerns, especially if it's a woman and it's not that big of a vessel, about where you're going to plug it in? Do you have any tricks about putting it into the ascending aorta, putting a patch of vein there so that you can make a nice hole punch? Because sometimes I find putting a radial artery into the aorta itself can be challenging. Sometimes I've actually widened into the internal mammary artery if it's a large internal mammary artery. So if you can just take a moment and give us your technical thoughts on that, I'd appreciate it.
So you essentially covered our program until someday. So no, I'm joking. Just.
Yeah, that was a lot of questions, but I don't. Yeah.
Perhaps if you come to the session at 2:30, you'll get some answers. The right internal mammary artery is a terrific artery, but you have to be careful with obese women, and we use vancomycin in the sternum at the opening and closing, and I think the right mammary has a limited application, although when you use it, it's terrific. With the radial, there are standard sort of antispasm regimens out there, so it's a matter of following those. And we certainly do not use the radial if it's less than 2 millimeters in size.
I think we have time for one more quick question.
My name is Joe Noor. I'm from Mississauga, Ontario. I have two comments, and they're both not exactly uncontroversial. First one is, since getting into formal practice, I've not been a fan of the beta. I don't believe in arterial grafting to the right side. Sorry, Dr. Puskas, those are two things I never brought back with me. And I've been very gratified since Dr. Schwann's presentations now, I think it was in EX the first time, and now to see that, this idea of complications with beta is real. So I'm wondering, I do use small radials, and I'm always very happy to see in the female patients that they seem to match up beautifully with the distals. We have a very small punch for the aorta. I've not had a problem with putting on the radial very often. I'm wondering, instead of talking about multi-arterial grafting and then commenting on the risks, should we, especially in the female patients, be talking about multi-arterial grafting using a LEDA and a radial first rather than the beta? So that's question one. Question number two, my program director happened to become the first female cardiac surgeon in Canada. I work out of Toronto with Maral Ozunian, who's chief at UHN. I would suggest in studying males versus female surgeons and all that, I have not really met very many or any average female cardiac surgeons. I've met a lot of almost average male cardiac surgeons. And that inherent bias has to be real. I mean, the vast number of male cardiac surgeons and perhaps a disproportionate amount of maybe just barely average surgery that gets done has to impact your outcome. So those are my two comments.
Well, I cannot really answer your first question, but I can tell you something that is an interesting information that is not out there yet. I think as a community, we are essentially doing what you are suggesting, because in the Roma trial, if you look at remember that in Roma, the choice of the second arterial graft is left to the surgeon. It's not by protocol. So the surgeon only knows that he or she has to use 2 arterial grafts, and then he or she can decide to use the Rita or the radial. When you look at the totality of the trial, the split between the two compounds is 50-50. But when you look at women in particular, it's 70% for the radial and 30% for the Rita. So I think surgeons are already preferentially using the radial in women, but I also know we have to close the session, so maybe we can discuss this offline. Okay.
Thank you all for the excellent session.